Now please welcome our moderator for today, Kathleen Koch, contributing editor at The Hill. She is joined in conversation with Kirsten Axelsen, health economist and senior policy advisor at DLA Piper.
Good morning, everyone. Welcome. Thanks for coming out on this chilly fall morning. So as you know, we're here to discuss Medicare Part D, and I know this can be daunting. I mean, it can be confusing. My husband actually, truth be told, worked for CMS for a bit, and when he turned 65 very recently, he turned to me, he said, "Can you figure this out for me?" He said, because you're the reporter, you do the research, this is really hard. And I think that says a lot. So I would love, Kirsten, let's jump right in. And you personally have spent years analyzing the impact that drug pricing and coverage changes have on the overall healthcare ecosystem. So when you look ahead to these changes for next year in 2026 for Medicare Part D, what should we be paying attention to? What do you think is the single most significant shift?
It's important to note that premiums are going up, but also formularies are getting more narrow. So what does that mean? Exactly. A formulary is a list of medications that are covered by your Part D plan and what you will pay for them out of pocket. When I say formularies are getting more narrow, that means drugs are getting dropped off the formulary.
People have fewer choices.
People have fewer choices. Importantly, as Adina mentioned, there is an out-of-pocket cap, which is a tremendous benefit. But if your drug is not on the formulary, you're going to pay out of pocket for that drug, and it does not count towards reaching the cap. So it's incredibly important to make sure that the drugs you need are on the formulary. Because you might say, oh, well, that drug costs $10,000, but I'll pay $2,100 and I'll be done. But if it's not on the formulary, you will pay forever that amount, or go seek patient assistance, of which there are patient assistance programs available, but you could end up in a financial pickle if your drug is not covered on the formulary. The other thing to note, as we've been watching, and including going into 2026, plans have been dropping out. This is not unexpected at all. The subsidy for higher cost beneficiaries, meaning the amount of money the government was giving to cover the expenses of higher cost people in Medicare, was reduced dramatically. At the same time, there's pressure to keep premiums low because that's what people look for. So the only way you can really get less funding from the government and keep premiums low is to reduce what you're offering. So you really need to be careful if your plan is no longer available. And in our research, we've noted in particular in rural areas, there's less access. There has been before. By access, I mean fewer choices of plans. So when you're choosing the next plan, really note carefully, are the drugs on formulary? Also note, are there co-pays or co-insurance? I think most of us don't know what the sticker price of a drug is. So when we're told we have to pay 25% of it, that might be a big number we weren't anticipating. And just be prepared. If you feel like financially, and I'll tell you, when I work through this with my parents, emotionally, they don't want uncertainty, even if they have the money saved. So make sure you're ready for uncertainty if you're choosing a plan with co-insurance, or also maybe you have to go through additional hurdles like prior authorization. And then also just really be prepared. If your drug is not on the formulary, that could be a significant out-of-pocket expense for you, and you want to do your best to find one where your drugs are covered. Even if you have to pay a higher premium, which I know is what most people look for, but do the calculation, is it better off for me to pay a bit higher premium if the medications that I need, which are typically more expensive than the monthly premium, are covered?
I know when we were discussing this prior to the event today, you were saying that seniors really need to think about what prescriptions they may need to take in the future. How do you do that when you don't even, you're healthy now and you don't know what might happen to you 10 years down the road?
It's really difficult, and there are not good indicators for this. In fact, I'm releasing research today where we surveyed people with cardiovascular disease. We did this in conjunction with two patient groups, and found that some of the measures people would like to know are what % of all FDA-approved drugs are on this formulary. And then we compared it to what's available in the quality measures that people see, the star ratings. So am I got a 3-star plan, a 4-star plan? The stars have been declining over time, unfortunately. But unlike if you go on Amazon or make other purchases where you might be able to read other people's experience, that's not available through Medicare. And so, part of what we would recommend is there should be measures that say this percentage of all FDA-approved drugs for this condition are covered. Because chances are, as we get older, all of us are going to get cancer or a neurological condition. And if you have that happen mid-year and you're in a plan, you're not going to have the coverage. So unfortunately,
isn't there a rule, though, that there are certain drugs, in certain classes that they have to cover, right? There's a list, correct?
There are 6
in certain categories.
Yes, absolutely. There are 6 protected classes where the plans do have to cover all or substantially all of the drugs. However, coverage does not mean it's easy for you to get. Coverage can mean there's coinsurance. Coverage can mean there's a prior authorization. Coverage can mean you have to try another drug and fail on it before you get the drug you want. And if you have
the step therapy.
The step therapy. If you have a painful condition like rheumatoid arthritis, that means more pain potentially. If you have cancer, that means you may not be getting the drug your doctor wants for you the first go. So just because something is covered doesn't mean it's going to be easy for you to get. So again, I would say do your best to look at the step edit and prior authorization criteria and then decide, is it worth it for me to go on the less premium plan if maybe there is one that doesn't have the same amount of hurdles available that might have higher premiums? And also just make that decision for yourself. Are you the kind of person who is willing and able to fight for what you need, or would you rather pay a little bit more if you can find a plan that doesn't have the same degree of restrictions?
Some of these impacts that you're describing, you saw this coming 2 years ago. Yeah, and it was for those at home who may not know, it was the Inflation Reduction Act that when that was passed, that mandated this cap on the drug expenditures or out-of-pocket costs to $2,000, then it will gradually creep up. So what are you finding in your recent analysis?
Yeah, and I wish I could say I was really prescient or a genius, but I think a number of us saw this coming. Again, it's the combination of the subsidy for high-cost beneficiaries came down very quickly. There's an out-of-pocket cap, which is a great thing, but it's not coupled with enhanced requirements to keep costly drugs on the formulary. So if you're saying people are going to spend less, the government's going to give the plans less, well, a few things are going to happen. Either plans are going to drop out because they decide it's no longer financially viable to provide the benefit. Because remember, there's 2 types of drug plans. There's one type that is drugs only, and for those
Part D, traditional Part D.
Yeah, the part that they called PDPs. For those plans, the dramatic decline in subsidy, they don't have a lot of room left to remain profitable, and they were already declining. There were already plans dropping out. So we are seeing more plans drop out. We are seeing, and this is something I track with a group of analysts that I work with at DLA Piper. We issue reports where we have seen the formularies are getting narrower. We looked at the drugs that were the most commonly dropped off of the formulary. Half of them were for an orphan disease.
And so the Orphan Drug Act doesn't protect them?
No, it does not require them to be on the formulary.
So just as you predicted,
Yeah.
there are people who are having fewer choices of plans and fewer medications to choose from as well.
Yes, and in fact, diabetes medication, which is the medication type most commonly selected for the Medicare price negotiation program, the copays have gone up by $11 to $14 per month on average. So what is happening is, again, what we would predict, the government is going to set the price of these drugs and people won't get any savings. The savings will likely accrue to the federal government.
Is all of the latest information out now about the list of drugs that will be covered by the various plans, the list of formularies? I know when we spoke, because of the shutdown, they hadn't been released. Is that out yet?
The formulary data is not out yet.
Still not. So how are people going to make their decisions this year? Don't they need to know what's going to be covered? I mean, that's what we're saying. When you
Yes.
pick a plan, make sure it covers your medication. How do we know that?
It's tough. It is tough for beneficiaries, and I think and it's tough for those of us who want to analyze the effects and be able to kind of call out as a warning system, like this is you should be aware. Look at your copays; they're going up. I think the formulary data will be released soon. Is anticipated to be released soon. And so that will be a resource available for people to choose.
I think speaking of drugs, I think a lot of seniors might wonder, well, if 40% of seniors have weight issues, then why aren't these weight loss drugs that could make us so healthy and save our lives, why aren't they covered? These are the GLP-1 inhibitors. Mm-hmm.
Well, in fact, and there's other drugs for weight loss. There's no coverage for drugs that are for weight loss. And in addition to the GLP-1s, I think there's 7 FDA-approved drugs for weight loss. That was something that was written into the Medicare Part D statute when it was designed over 20 years ago. And including smoking cessation drugs were originally not covered. These were seen as lifestyle choices. We've learned, I think, a lot more about addiction, about obesity since then. And in fact, the exclusion from smoking cessation drugs being covered was removed because we've learned more about the science of addiction. And also there's good treatments available. Unfortunately, with drugs for obesity, even though we know infinitely more about obesity and we know that it is a disease and that just telling people to stop eating or exercising is not effective for the vast majority of them, these drugs still aren't covered. And if they're covered, there will be a short-term cost impact. But we also know that when people lose weight, they cost less and they're healthier. So it's a short-term cost impact that's an investment in future savings and, frankly, the next generation. Not only is obesity costing people in terms of their direct health care, it costs hospitals in terms of staff and injuries. It's a real problem, and there's a great fix. There's a number of great technologies available to help people lose weight that are fortunately not covered by Medicare.
So this is the first year that the negotiated drug prices actually go into effect in Medicare. It was 10 drugs that they negotiated. So will Medicare recipients, will the beneficiaries benefit from that? Will they see drug costs come down?
It depends. People who have copays, for example, we are seeing those copays, and a copay, remember, is a fixed amount of, your plan says every month you're going to pay $60. And that might go up to $70 next year. And if your drug cost $800 previously and now it costs $400, you're still paying that copay. If you have co-insurance, meaning you're paying a percentage of the price of the drug, then it could be that you'll spend some less money initially. The good thing is that there is an out-of-pocket cap. So at some point, people will be reaching that out-of-pocket cap for their covered drugs. So even if they end up paying, a bit more initially, the people who are definitely not paying more are the ones who have higher copays and higher co-insurance, but don't reach that out-of-pocket cap. And so it's not the case that these benefits will flow necessarily to the beneficiaries.
So looking at what was intended by the Inflation Reduction Act and then what's actually happening, do you think we need to have more intervention by policymakers on the federal level, and I don't know if the state level can do anything to help?
Yeah, I mean, yes, I think something needs to be done about the formulary review process. It's not sufficient to just say a drug is, a certain number of drugs are covered per class. We now know, and there's more research every day, that not everybody is treated by the same drug as effectively as the next person. And just because there's one FDA-approved drug or 2 FDA-approved drugs in a class covering, think about mental health. Think about how unbelievably hard it is to treat depression. We're learning more about how unbelievably hard it is to treat immunological diseases and pain. There needs to be multiple choices available. So whether it's CMS reviewing the formularies or, as I mentioned, some sort of a quality measure that could say, this plan has X% of all drugs covered in these therapeutic categories. So you have a sense of, is this a plan with broad coverage or narrow coverage? Is this a plan with a lot of prior authorizations or fewer prior authorizations? People can only really go and look up their own drug. There's nothing that kind of gives you an indication of, if I get stuck, if I get sick, what's going to happen when I go to get treated. And as we age, we're all going to get sick. We're all going to get more stuff. It's, or hopefully many of us won't, but it is sort of the trend of what happens, right? And so, yeah, I would like to see more oversight by CMS of the formularies and also better measures that let people know what's available to them in their plan.
So if you could pick one reform idea that you could put into effect tomorrow that would make things better, what would that one be?
That's a great question. Oh my gosh, I wish I had that. I wish I had that crystal ball. It would be the oversight of the formularies and the ability to let people know when. And I'm responding to this in terms of sort of what I think would make beneficiaries' lives better immediately. So the ability to know more strongly what's on the formulary. There are structural changes that you could make to the benefit design, such as changing the way the drugs are selected and the price controls. I don't think those are really helping people, and they're deterring investment and innovation. So, there's other changes I would make probably in the longer term, but that's what I would say. If something could happen tomorrow, it would be to give people a better sense of what's covered on their formulary when they go to pick a plan.
Is there anything that beneficiaries themselves or people watching or people in the audience can do to push back against any of this or to advocate? Because I just can imagine, especially a lot of seniors feeling helpless, feeling frustrated. I had a plan and now it's gone. Or I had these prices and then they were here and now they're there. I mean, what can they do?
Well, I'm going to deflect this one to the Alliance for Aging Research team because they do have resources and approaches to help people push back. I guess the only advice I would give is if you're in a plan and your benefits have declined, do your best to switch plans if one is available to you. But again, I'm going to turn the advocacy over to the advocates because I'm a health economist. I'm going to say they're going to be better at knowing what to do.
You've written a lot about the need, obviously, for innovation, for access, and that mandates may not be the answer. So can you elaborate your thoughts on that?
Yeah, I mean, telling companies to do something and then not supporting them with the right financial structure doesn't work. That makes companies drop out, right? Like if you put in incentives to develop a new medicine, we've seen a lot of companies go after priority review vouchers or invest more in therapeutic areas where there's other incentives that either give them more time on the market or faster review by the FDA. If we make it a category difficult to be in, and I think we see that in antibiotics and vaccines where there's fairly low rates of reimbursement. There's a lot of liability involved, in particular in being in vaccines. We've seen companies drop out from investing. So you can't just direct something to happen. And also you have to think, and I think that's also what's happening a bit in the Medicare Part D benefit is we've cut a lot of things, a lot of reimbursement for the plans, and then we're expecting them to offer the same, and which is why there's a big premium support program going on right now. The government had to step in and offer additional money to the plans. Otherwise, the premiums would have gone up a lot. And that's a temporary program. And we're going to be facing pretty soon a situation where if that premium support comes off, people are going to be paying a lot more per month for their drug benefits.
What about the issue that Adina touched on in the first panel with some of these independent pharmacies who find themselves in the position of someone coming in with a prescription that they have to fill, but they have had to buy the drug at a higher cost than they can sell it. It's every transaction like that for them will be a money-losing prospect. How do you stay in business that way? Something needs to be figured out because also think about this, especially these first 10 drugs and even going forward, they're choosing among the costliest drugs to the government. A drug can be costly to the government in two ways. It can have a high price tag or a lot of people can take it. And in this first 10 drugs, a lot of people are taking them. And so you're going to have people going for their anticoagulants, for their diabetes medications, chronic disease medicines that you're not supposed to skip, and the pharmacy can't go underwater. It's not like pharmacy margins are enormous, right? Like they're pharmacies. They're struggling already. We're seeing pharmacies closing all the time. So we can expect that these drugs are going to be stocked. No business owner would do this, right? And when you're in the position of healthcare provision, it's even more urgent, but we can't expect that a business is going to just be able to stay underwater and float the difference and stay available. So they're just not going to stock these drugs. So like any price control situation, we've got the government setting the price, and it will result in shortages. Shortages. Mm-hmm. Shortages of needed medication. Yes, and not shortages in the way we think it's not produced enough, but if it's not available at your pharmacy, that feels like a shortage just as much because it's not there for you when you go. So who does that impact most then? Does that impact beneficiaries in rural areas, in urban areas?
more in rural areas than urban areas because there are not as many pharmacy choices. It affects people who rely on community pharmacies that don't necessarily, that don't have the ability to manage that risk.
So I know people may say, well, I'll find another way to get my prescriptions. Trump RX, right, was introduced earlier this year. There's Mark Cuban's operation that also offers low-cost drugs. Are any of those something that are helpful to Medicare beneficiaries, to seniors?
I mean, people should look into it. So far, there's a fairly limited number of drugs covered in the Trump RX program. You can also go directly to the company's, website. Many of them have patient assistance programs. Similarly, with the, with the tools, other types of tools, and also make sure that it really is a better deal for you. I think if you look at what the copays are or what the patient assistance amount might be directly from the drug company, you may find that you could pay less doing that than you might through Trump RX or another. So just shop around, but remember that's time-consuming and hard. So if you can find coverage through a Medicare Part D plan, that is going to be the most time-efficient path to getting your drug.
Right, and obviously you want to hit your cap.
Yes.
Right.
Yes.
And, because then everything's covered after that.
Absolutely, and that's another good point. If you're going to patient assistance or you're going to pay out of pocket directly, that is not helping you reach that cap.
So when we look down the road to the future, what's around the corner that people need to be thinking about in the way of policy changes, maybe not for 2026, 2027, 2028? Can you look around the corner for us? Crystal ball?
I'll do my best.
Okay.
I'll do my best. So, another 15 drugs were selected for the price setting. It's getting more into the oncology arena. And so we'll know the prices for those drugs that were set by the government shortly. The next tranche of drugs that are going to be selected are going to be both physician-administered drugs as well as pharmacy drugs. When the government sets the price of those, it's going to affect what physicians get paid to use those drugs. And similar to the pharmacies, if physician pay goes way down, you may find either physicians not willing to administer those drugs or practices not being able to sustain themselves financially. Perhaps more of them get acquired through private equity and other arrangements, so you may see some impact on the physicians that are available. And then, we're also starting to see already changes in investments, whether early stage investments. When I talk to investors, they have a decent grasp of the Inflation Reduction Act. And what I hear is there's so many uncertainties in drug development. There's so many ways this can fail. Why would I also be pursuing a drug that has a big Medicare population and might have a price control? Like, why would I add that other element of failure when there's so many other promising areas of science to prosecute? So I would be watching for the impact of this on investment in drug development and on investment in post-market study, which is the kinds of things you do after a drug is approved. You study it maybe in frail elderly, you would study it in children or other comorbidities that are typically not included in the regular clinical trial. So that's what I'd be watching for is, are we gonna see differences in the quantity of clinical trials that are initiated for new or post-market medicines?
I want to jump back to what you were mentioning about physicians. So you said there could be a reduction in these drugs that doctors administer in their offices. They may not want to. So what are we talking about? Who does that then affect?
Those drugs are, physician-administered drugs tend to be for cancer, for immunological conditions. And I don't want to get too policy wonkish, but the way physicians are reimbursed right now is they buy the drug and they get reimbursed the drug's price plus a bit. And that amount of money that they keep is part of what sustains their practice, right? That's part of what pays for administering the drug, the nurses, the staff time.
These are expensive.
These are expensive. And so if you're dropping the price of the drug by 50%, that physician's pay just got dropped by 50% for administering that drug. So they may switch to drugs that don't have a price control if that's available, which cost more money for the federal government, and patients if they're paying 20% out of pocket if they don't have a Medigap or other wraparound plan. But also if it's a certain class where there's only one drug available and that drug has a price control, the physician may say, I'm just not going to stock this one anymore and administer this one anymore because I'm not able to sustain my practice economics.
Wow. So patients would just have to shop and shop, go from doctor to find someone who would administer it.
And people with serious conditions who already have to go to the doctor to get infusions. Yeah.
And then you mentioned drugs that are being dropped from the formularies are most likely, or what you're seeing, is that they're frequently these orphan drugs. So what's happening now to that community? What are their options?
If they can find another plan that does cover the drug, then they may be able to get coverage. If you can't, then it's going to patient assistance or trying to get help through a foundation.
How exasperating is this as a policy analyst to see the direction we're going? I guess, did lawmakers not get this when they passed the Inflation Reduction Act?
I don't know what they got or didn't get. The Inflation Reduction Act reads very emotionally to me. It has a lot of things in it, the government setting the price, the differences on the biologics and the small molecules. It doesn't hold together from any kind of economic perspective or improve healthcare delivery. I mean, even just the fact that they're targeting drugs in Medicare, many of whom are already deeply discounted. The prices the government's getting is already what the market was getting. Says to me it's more of an emotional than a rational decision. And also just going after the drugs in isolation from the hospital payments or the physician payments is not a way to save money. Either you're going to reduce the drug spend and end up with more medical spend, or it's just, even if you are successful in reducing the drug spend, it's not going to save the Medicare program. So it doesn't read to me like it was done thoughtfully. It feels like it was done punitively. And that's frustrating, because also the federal government's not saving any money. They've already had to give back in premium subsidies the amount, or possibly more than the amount, they saved with the first 10 price controls. And then people are spending more. So it's not even saving money.
So when you talk about the need, though, for a fix, what are the odds in this Congress?
Oh, gosh. I'm
People
not going to predict anything about this Congress.
To make the system work.
Yeah, I'm not going to predict anything about this Congress. I am going to say I think a lot of seniors are going to be unhappy when they see their choices. And let's be hopeful that's motivating.
And they will call their congressmen and women?
So, or call the Alliance for
Senators?
Aging Research and find out what to do. But yeah, I think this is going to drive a lot of discontent. Like, wait a second, the government's setting the price. I was supposed to get all these savings. And I don't feel like people are going to think they're saving money.
So your dad, what's he saying to you as he's looking
my
at this? Is he
choosing?
shopping? And
I mean, yeah, my dad's taking one of the 10 drugs that has the price controls. And he called me and said, it's so exciting, I'm going to save money. And I was like, Dad, I don't think that's the case. So, and I know many of us help our parents choose plans. Older people really want financial predictability. In my experience, my dad wants financial predictability, and it's not coming to him, and I think that's very frustrating.
so do you leave the stage today optimistic, pessimistic, hopeful? What would you say?
Hopeful, let's say. Let's say hopeful. I am hopeful that people will engage, reach out to their members of Congress, complain to their plans, and ask for better coverage, but also ask for better indicators of what's really covered in their plan, so that they can have a hope of making different choices. But I do want to say, if you're in a rural area and there's 2 standalone drug plans available, there might not be better choices. And that's, again, the concern I have with all the plans dropping out, is the way the drug benefit was designed is, it's okay if you want to go with a cheap plan and narrow coverage, and that's your preference, but then there's also this other plan that has better coverage, it's a little bit more expensive. When you start losing that variation, then you start losing the ability to pay for what you need, which I think people are willing to do if they have that option.
Kirsten Axelsen, with Senior Policy Advisor with DLA Piper. Thank you so much for your insights.
Thank you.
Really excellent. Thank you very much.
Thank you. Thank you. you.